A 56-year-old man with non-coronary artery disease presents to the emergency department complaining of chest discomfort and palpitations for 2 hours. His vital signs on arrival were as follows: blood pressure 122 versus 76 millimeter Hg, heart rate 180 per minute, respiratory rate 22 per minute, temperature of 37 degree, 98.6 Fahrenheit, and SpO2 98% on room air. A 12-lead electrocardiogram demonstrated ST segment elevation in the anterolateral leads. The troponin level was 0.8 nanogram per ml. Normal. The patient declined primary percutaneous intervention and was treated with antifibrinolytics in the coronary care unit. After 1 hour of treatment, the patient loses consciousness and the blood pressure falls to 60 to 40 millimeter Hg. Cardiac monitoring shows the below ECG pattern in lead 2. What is the most likely cause of his condition? Option A, premature ventricular contractions. Option B, monomorphic ventricular tachycardia. Option C, mitral regurgitation. Option D, third-degree heart block. Option E, acute pericarditis. The correct answer is B. The electrocardiograph demonstrates a monomorphic ventricular tachycardia. Is depicted by uniform wide QRS complexes more than 120 milliseconds. The complications of myocardial infarction include cardiogenic shock, arrhythmias, mechanical complications, ventricular septal rupture, free wall rupture, and mitral valve dysfunction, mural thrombus formation, and inflammatory complications, early pericarditis, and post-MI syndrome. Ventricular arrhythmias are the most common complications of an acute MI. Prompt revascularization with primary percutaneous intervention and drug therapy with antiplatelet agents, statins, AEC1s and beta blockers have markedly reduced the incidence of ventricular arrhythmias occurring within 48 hours of the onset of an acute coronary syndrome. The mechanisms involved in post-MI ventricular arrhythmia are a reentrant mechanism and automaticity, with the reentrant mechanism being the most common. Formation of re-entry circuits at the confluence of viable and necrotic myocardium occurs in the immediate post-myocardial infarction period. Electrophysiological remodeling, together with structural remodeling, supports reentrant excitation in infarcted myocardium. Automaticity is caused by accelerated and abnormal impulse generation in the ventricle. The incidence of ventricular fibrillation is 2% to 4%, whereas premature ventricular contractions (PVCs) occur in approximately 98% of patients. Accelerated ventricular rhythms often occur during the reperfusion phase of PCI, which are self-limiting and usually do not require treatment. Aminodarone may be used in patients with an acute MI and non-sustained ventricular tachycardia or post-defibrillation for ventricular fibrillation.